Welcome to the deep dive. I've been really digging into some medical texts lately.
Oh, yeah.
Specifically around the heart, cardiovascular physiology, pharmacology. Pretty complex stuff.
It definitely can be.
Yeah, but I've tried to pull out what feels like the really crucial bits, a kind of snapshot.
Right, like getting the high-value knowledge without getting totally bogged down in every single detail.
Yeah.
We're aiming for the core ideas, the compelling insights.
Exactly. It's about understanding the fundamentals, right?
Yeah.
How the heart works, how we help it.
From measuring output to how drugs work in critical situations.
Precisely. So enough jump in. One really basic thing is just figuring out how much blood the heart is pumping. The sources mention the Fick equation.
Ah, the Fick equation. Yeah, it's foundational, even if it's not used bedside constantly now.
So what's the principle?
It basically says your cardiac output, how much blood you pump per minute, is linked directly to how much oxygen your body uses.
Okay.
And specifically, the difference in oxygen between the blood going into the lungs and the blood coming out.
Like tracking the oxygen uptake.
Exactly. It's oxygen consumption, VO2, divided by the difference between arterial oxygen, CaO2, and mixed venous oxygen, CVO2.
Right. VO2 over CO2 minus CVO2. And they gave an example, VO2 250 millsman.
Yeah, an arterial O2 of 13.5, venous of 8.16.
Right, plug that in, multiply by 10 for the units, and you get 4.68 liters per minute.
Pretty straightforward concept, yeah.
But the sources also say it's tricky to use in practice.
Well, yeah. Measuring that oxygen consumption accurately, the VO2, that needs some pretty cumbersome equipment. Not always practical.
Okay.
Plus, cardiac output might actually change while you're trying to get the blood samples.
Ah, like chasing a moving target.
Kind of. And then there's always the chance of just sampling errors, lab variability, the usual stuff.
Makes sense. Conceptually elegant, practically challenging.
Precisely.
Okay, let's pivot completely. Protecting the heart during surgery, like bypass, that sounds intense.
Oh, it's a fascinating technique. Cardiopulmonary bypass, yeah. The key is using what's called cardioplegia solution. Yeah. It's infused directly into the heart's arteries, and it's cold, like 4 degrees Celsius.
4 degrees, wow.
And it's got a high concentration of potassium chloride in it, usually around 20 milliequivalents per liter.
So a cold potassium bath, essentially. What does that do?
Two main things. The cold induces rapid hypothermia in the heart muscle.
Chills it right down.
Yep. And the high potassium stops the heart's electrical activity, makes it go completely still and relaxed, or flaccid.
Okay, so you stop it from beating and cool it way down. Why?
To drastically, and I mean drastically, reduce its need for oxygen, its metabolic rate just plummets.
The numbers were pretty stark, weren't they?
They really show it. A normal beating heart at body temp, 37C, uses maybe 8 to 10 milliliters of oxygen per 100 grams per minute.
Okay, that's the baseline.
Now, cool it down to 22C, even if it's just fibrillating, twitching. That drops to maybe 2 millimol.
Significant drop already.
But get it completely still, electromechanically quiet at that same 22C. The oxygen demand goes below 0.3 millimolar per 100 grams per minute.
Wow. Less than 0.3. That's barely anything compared to the start.
Exactly. It's like putting the heart into suspended animation almost. Buys the surgeon's critical time and protects the muscle.
That must have revolutionized heart surgery outcomes.
Absolutely. It's a cornerstone. Allows for longer, more complex repairs with much better results. Minimizing that oxygen debt is key.
Incredible stuff. Okay, let's shift again. Medications affecting heart strength, inotropy, right?
That's the term, yeah. Inotropy is the force of the heart's contraction.
And lots of drugs boost that, like epinephrine.
Right. Epinephrine, dopamine, dobutamine. They're positive inotropes. They make the heart pump harder. But the sources highlight an exception, phenylephrine.
Ah, phenylephrine.
What's its deal? Phenylephrine is mainly an alpha-adrenergic agonist. Think of it as primarily squeezing the blood vessels, the pipes.
Okay, so it tightens the vessels.
Yeah, increases systemic vascular resistance. Raises blood pressure that way, but it has very little direct effect on making the heart muscle itself contract stronger. Minimal inotropy.
So pressure goes up, but not because the heart's pumping harder, necessarily.
Exactly. It's more about increasing the resistance the heart pumps against.
Interesting distinction. Now, how does this tie into aortic stenosis?
Okay, so critical aortic stenosis is when that main valve leaving the left ventricle is really narrowed. It's like trying to pump water through a pinched hose.
Hard work for the heart.
Extremely hard.
Yeah.
The left ventricle has to generate much, much higher pressure, systolic pressure, just to force blood out into the aorta and maintain stroke volume.
And that leads to symptoms, I gather.
It does. The classic triad is angina, chest pain,
Right.
syncope or fainting.
Okay.
and eventually signs of congestive heart failure. It's the heart struggling against that blockage.
Does the heart muscle change?
Yeah, over time, the left ventricle muscle thickens. That's left ventricular hypertrophy. It's adapting to the high pressure.
Trying to get stronger.
Initially, yes, but eventually that thick muscle can become stiff, less able to relax properly, and its actual contractility can start to decline. It becomes less efficient.
So, for someone with this condition needing, say, gallbladder surgery, what are the big concerns for anesthesia?
Oh, it's high stakes. The main goals are keep a normal heart rhythm, specifically normal sinus rhythm.
Right.
Avoid big swings in heart rate, especially going too fast. Tachycardia is really poorly tolerated.
Why that?
Because a fast rate cuts down the time the heart has to fill and also the time for blood flow to the heart muscle itself, which we'll get to later.
Yeah, less filling time, less perfusion time.
Exactly. You also need to keep their blood pressure, the systemic vascular resistance, stable and manage their fluids very carefully. No big shifts.
So stability is key. What about those rapid heart rhythms like SVT or new AFib?
Yeah, supraventricular tachycardia, especially new onset atrial fibrillation. That's a major problem.
Why?
Because in aortic stenosis, the heart depends on that coordinated atrial kick to help fill the stiff ventricle. Lose that with AFib, plus at a rapid rate, blood pressure can plummet.
And the heart muscle itself suffers.
Big time. You risk severe hypotension and myocardial ischemia, lack of oxygen to the heart muscle. So if that happens, you need to treat it aggressively, often with electrical cardioversion, to get the rhythm back to normal quickly.
Right. Restore sinus rhythm ASAP. Okay, shifting gears again. PEEP. Positive and expiratory pressure. Used with ventilators.
Correct. It's basically applying a bit of constant pressure to the airways, even when the patient is breathing out.
And the main reason is?
Primarily to improve oxygenation, get more oxygen into the blood, especially when you're needing to use high concentrations of inhaled oxygen, FiO2, above, say, 0.5 or 50%.
To avoid oxygen toxicity risks.
Exactly. High FiO2 for long periods can damage the lungs. PEEP helps you oxygenate better, potentially allowing you to lower the FiO2.
How does it actually work? What's the mechanism?
It helps keep the tiny air sacs, the alveoli, from collapsing completely at the end of exhalation.
Pops them open a bit.
Sort of recruits them, yeah. Keeps more of them open and participating in gas exchange. This increases lung compliance, makes the lungs easier to inflate, and boosts the functional residual capacity, FRC, the amount of air left after exhaling.
And that helps oxygen get across.
Yes, by improving the matching of ventilation, airflow, and perfusion, blood flow, in the lungs. It reduces shunt blood passing through the lungs without picking up oxygen.
Sounds pretty beneficial. But the sources mention downsides too, hazards.
Definitely. PEEP isn't benign. A major potential issue is decreased cardiac output.
How come?
The increased pressure inside the chest can compress the heart and the big veins returning blood to it, reducing preload and thus output.
Okay, less blood back means less blood pumped out.
Right. Another big one is pulmonary barotrauma, lung injury from the pressure.
Like popping the air sacs.
Essentially, yeah. Overstretching and rupturing alveoli. Air can leak out, causing a pneumothorax.
A collapsed lung.
And potentially a tension pneumothorax, which is a real emergency. Air builds up under pressure, collapses the lung, shifts everything in the chest, compresses the heart. Very bad.
How would you know that's happening?
You'd see a sudden, sharp deterioration. Oxygen levels crash, blood pressure drops. It's abrupt.
And the treatment?
High suspicion. Confirm with a chest x-ray if possible, but if it's tension, you need to decompress immediately. Stick a needle or chest tube in to let the trapped air out.
Urgent stuff. Any other risks with PEEP?
It can sometimes increase fluid buildup in the lungs, extravascular lung water, and can also shift blood flow around within the lungs. So, powerful tool, needs careful monitoring.
Absolutely. Okay, let's zoom back to the heart itself. Even when we're resting, it's working hard, right? Needs a lot of fuel.
Oh yeah, absolutely. The heart's a metabolic powerhouse, even at rest. Coronary blood flow, the blood flowing through the heart's own arteries is pretty high.
How high?
Typically around 225 to 250 milliliters per minute. That works out to about 75 milliliter per 100 grams of heart tissue per minute.
And as a percentage of total cardiac output?
It's about 4 to 5%, which might not sound huge, but consider the heart size relative to the whole body.
Right. And its oxygen use.
That's even more striking. At rest, the heart consumes about 8 to 10 millimeters of oxygen per 100 grams per minute.
Okay.
That accounts for roughly 10% of your entire body's oxygen consumption while you're just sitting there.
10% just for the heart. Wow.
Tells you how much work it's constantly doing.
It really does. Now, speaking of coronary arteries and things going wrong, a rare but serious issue with PA catheters, pulmonary artery rupture.
Yeah, PA catheter-induced pulmonary artery rupture.
Yeah.
It is rare, thankfully, but very serious when it happens.
What's the main sign?
Hemoptysis, coughing up blood. Can be anything from a little bit to a massive amount.
Scary. What's the immediate management?
Priority 1 is protect the other lung. You need to isolate the bleeding lung. That usually means intubating with a double lumen endotracheal tube.
So you can ventilate the good lung separately?
Exactly. Prevents blood from flooding the healthy lung. Interestingly, the sources mention that having atherosclerosis, plaques, in the pulmonary artery doesn't necessarily increase the risk of rupture where the catheter tip usually sits.
Oh, why is that?
Those plaques tend to be more common in the bigger central parts of the PA, not usually out in the smaller branches where the balloon might be inflated or the tip wedged.
Got it. Okay, let's talk drugs again. Protamine. Used to reverse heparin, right?
That's its main job, yes.
Yeah.
Neutralizes heparin's anticoagulant effect.
But it can cause reactions, allergic type reactions.
It can. Anaphylactic or anaphylactoid reactions can occur. They're not super common. Our sources say less than 5% of all anesthesia-related allergic reactions involve protamine, but they can be severe.
When do they typically happen?
Usually quite quickly, within 5 to 10 minutes of getting the protamine.
Are some people more at risk?
Yes, there are known risk factors. Prior exposure to protamine is one maybe from a previous surgery, or even from certain types of insulin like MPH or PZI, which used to contain it.
Insulin. Okay.
Also, allergies to fish, since protamine is derived from fish sperm.
Right, the fish connection.
And maybe surprisingly, men who've had a vasectomy seem to have a slightly increased risk.
Vasectomy, how does that fit in?
The theory is they might develop anti-sperm antibodies that could cross-react with protamine. It's an interesting link.
Definitely. Can you do anything to prevent these reactions in high-risk folks?
Pre-treatment with antihistamines, H1 and H2 blockers, and maybe corticosteroids is sometimes considered. But the most important thing, if someone has a known history of a severe anaphylactic reaction to protamine, you just avoid it altogether. Find an alternative.
Absolutely. Makes sense. How does it actually neutralize heparin? What's the chemistry?
It's basically an acid-base reaction.
Yeah.
Heparin is strongly acidic, protamine is strongly basic. They bind together electrostatically, form an inactive complex, and heparin can't work anymore.
And the dose?
Rule of thumb is about 1.3 milligrams of protamine for every 1 milligram or 100 units of heparin estimated to be circulating.
Okay. And the sources mentioned 20,000 units of heparin is about 200 milligrams.
Yeah, that's a useful conversion.
What about heparin's duration? How long does it last?
Its half-life at normal body temperature 37 C is around 1.5 hours.
But temperature matters.
It does. If the patient is colder, say 25 C, like during some types of surgery, heparin metabolism slows way down. It lasts longer. Something to factor in.
Very interesting. Okay, back to coronary blood flow. You mentioned earlier it's not continuous like other organs.
Right, especially for the left ventricle, it's quite unique. Coronary perfusion is intermittent.
What determines the flow then?
It's driven by the pressure difference between the aorta during diastole, the relaxation phase, and the pressure inside the ventricle at the end of diastole, the end diastolic pressure.
So it fills mainly when the heart relaxes?
For the left ventricle, yes, almost entirely during diastole.
Why only diastole for the left?
Because during systole, when the left ventricle contracts really forcefully, the pressure inside the muscle itself gets so high that it physically squeezes the small coronary blood vessels within the muscle wall shut, compresses them.
Wow, it squeezes its own blood supply off?
Pretty much, during contraction. So blood can only flow effectively into the left ventricular muscle when it relaxes during diastole.
And that explains why a faster heart rate is bad for coronary perfusion.
Exactly. Faster heart rate means less time spent in diastole. Shorter diastolic period equals less time for blood to flow into those left ventricular coronary arteries.
Makes perfect sense. What about the right ventricle?
The right ventricle generates much lower pressure when it contracts, so it doesn't squeeze its coronary vessel shut as much. It gets blood flow during both systole and diastole.
Big difference between the two sides. Fascinating. Okay, another tool mentioned, thromboelastography, or TEG. Sounds complex.
It gives a really dynamic picture of blood clotting. It's a viscoelastometer.
Viscoelastometer.
It measures the viscoelastic properties, basically the thickness and stretchiness of blood as a clot forms and changes over time.
So it sees the whole clotting process?
Pretty much from start to potential breakdown. It measures several things.
Like what?
The R value is the reaction time, how long it takes for the clot to start forming. Normal is like 7.5 to 15 minutes.
Okay.
The K value is clot formation time, how fast it builds up strength. Normal, 3 to 6 minutes.
Right.
Then MA, maximum amplitude, that's the peak clot strength, influenced by platelets, fibrinogen. Normal is 50-60 millimeters.
Got it. Peak strength.
And finally, A60. That's the amplitude 60 minutes after the MA. It tells you about fibrinolysis, how quickly the clot is breaking down. Normal is usually MA minus maybe 5 millimeter.
So you can see if it's forming too slow, too weak, or breaking down too fast.
Exactly. The source showed a TEG trace that was typical for fibrinolysis, excessive clot breakdown. Very useful in managing bleeding or clotting issues.
Powerful diagnostic. Okay, now for severe heart failure, ventricular assist devices, VADs.
Yeah, VADs. These are mechanical pumps implanted to help a failing heart.
When medical treatment isn't enough.
Right. For end-stage heart failure, you can have left-sided ones, LVADs, right-sided RVADs, or even BiVADs supporting both sides.
Why would someone get one? What are the goals?
Several reasons. Sometimes it's a bridge to recovery, hoping the heart will improve. More often, it's a bridge to transplantation, keeping someone alive until a donor heart is available.
Okay.
And increasingly, it's destination therapy, long-term support for people not eligible for transplant. Some live for years quite well with LVADs.
Amazing technology. But managing anesthesia in a VAD patient, challenges there.
Sure.
Especially low blood pressure.
Oh, yes. Hypotension management is tricky. LVADs especially are very preload dependent.
Meaning they need enough blood coming into them to pump effectively?
Precisely. Anesthetics often cause vasodilation, veins relax, less blood returns to the heart, preload drops.
So just cranking up the VAD speed won't help.
It can actually make things worse if the preload is too low. You can get the suck down effect. Yeah, the ventricle gets sucked empty, the walls might get pulled into the VAD inflow, pump function fails, hemodynamics collapse. Very dangerous.
Yikes. So what do you do for low pressure?
Priority is restoring preload, fluids, maybe Trendelenburg position, head down, to help venous return.
Okay, fluids first, then drugs.
Vasopressors like phenylephrine are often used first line because they increase resistance without boosting heart contractility much, which is usually desired. Ephedrine can be used, but cautiously, especially if the right ventricle is weak.
So fill the tank, then maybe squeeze the pipes, but don't just speed up the pump blindly.
That's a good way to put it.
Okay, let's talk about adenosine again for rapid heart rhythms, SVTs.
Yep, adenosine is excellent for terminating many SVTs, even those involving WPW syndrome.
WT Wolf, Parkinson, White.
Right. The exception is atrial fibrillation with WPW and a YQRS complex on the ECG. Adenosine is contraindicated and can make things dangerously worse.
Okay, noted. How's it given?
Rapid feed push, usually 6 milligrams first. If that doesn't work, wait a minute or two, then try 12 milligrams.
And it works fast.
Very fast metabolism, super short half-life. Liver and kidney function don't really affect it.
But other drugs can interfere.
Definitely. Dipyridamole, an antiplatelet drug, blocks its uptake, makes it much stronger and longer lasting.
So you need less.
Yes. If someone's on dipyridamole, or if you give it via a central line, cut the initial dose in half, maybe 3 milligram, to avoid prolonged standstill, asystole.
Okay. And things that block it.
Methylxanthines.
Like caffeine.
Yeah, or theophylline for asthma, or the older drug Amrinone. They compete with adenosine, so you might need higher doses to break the SVT.
Good to know about those interactions. Okay, temperature monitoring. Seems basic, but getting it right is crucial, especially core temp.
Absolutely vital. Several sites give reliable core temperature readings, even when temps are changing fast.
Which ones?
Pulmonary artery via a PA catheter, discal esophagus, tympanic membrane, the eardrum, and the nasopharynx.
Back of the nose-throat area.
Right. Those track core temp well.
What about oral, armpit, rectal?
They're usually reasonable estimates, but less reliable during big, rapid temperature swings, like cooling and rewarming for bypass surgery. They can lag behind the true core temp.
And the bladder temperature.
Also reasonably good, but can be affected by how much urine is flowing. So assessing rewarming after bypass often involves looking at both a true core site and the bladder temp for a complete picture.
Multiple data points are better. Makes sense. Now, echocardiography during surgery. If you're looking for ischemia, lack of blood flow, is there a preferred view?
Yes, the transgastric mid-papillary short-axis view is often considered the best for ischemia monitoring.
Transgastric short axis. Why that one?
Because it gives you a cross-section of the left ventricle right at the level of the papillary muscles. And from that viewpoint, you can see segments of the heart wall supplied by all three major coronary arteries: the LAD, the circumflex, and the RCA.
Ah, so it covers all the bases, supply-wise.
Exactly. Other standard views, like the four-chamber or long axis, tend to show walls primarily supplied by only one or two of those arteries.
So you might miss ischemia happening in a region not covered by that specific view.
Potentially, yes. The transgastric short axis gives the broadest surveillance for new wall motion problems that might indicate ischemia across all territories.
Yeah.
Most sensitive single view for that purpose.
Got it. Wider view, better detection. Okay, big topic. Sudden cardiac arrest, SCA. What's the usual first rhythm seen when it's witnessed?
Most often, it's ventricular fibrillation VF, chaotic electrical activity.
The key to survival.
Early, high-quality CPR and rapid defibrillation, shocking the heart back to a normal rhythm.
What are the current recommendations for healthcare providers if they see an arrest happen?
If an AED, an automated external defibrillator, is right there, use it immediately.
Heck not.
Start CPR straight away. 30 compressions and 2 breaths. Keep going until the AED arrives.
And the shocking part, the guidelines changed.
Yes, significant change. For modern biphasic defibrillators, the old 3-stacked shock sequence is out. Evidence showed that if the first shock doesn't work, immediately shocking again is unlikely to help and might even cause harm by interrupting chest compressions.
So what's the flow now?
1 shock. Then immediately resume CPR for 5 cycles, which is about 2 minutes. Then check the rhythm and pulse again.
Okay, shock, CPR, reassess.
Right. If VF is still there, give another single shock. And if you have IV or IO access, consider drugs like epinephrine or vasopressin around that time.
What about older defibrillators? Monophasic ones?
For those, the 3-shock sequence might still be acceptable, but all adult shocks should be at the maximum energy, 360 joules.
And there was a note about unwitnessed arrests found by EMS.
Yeah, if it's an unwitnessed out-of-hospital arrest and the EMS response time was more than, say, 4 minutes, the recommendation is to do 5 cycles of CPR first, before even checking the rhythm or trying to shock.
To prime the pump, basically. Improve the chances of the shock working.
That's the idea. Get some circulation going first.
Critical updates. Okay, the renin-angiotensin-aldosterone system, RAAS, big player in blood pressure.
Huge. It's a cascade controlling blood pressure and fluid volume. Kidneys release renin,
Which axon?
angiotensinogen from the liver, making angiotensin the first. Then ACE enzyme converts that to angiotensin the second.
And angiotensin the second is the main player.
It's a powerful vasoconstrictor, tightens blood vessels. And it also tells the adrenal glands to release aldosterone.
Aldosterone makes you hold on to salt and water.
Exactly, which increases blood volume. Both effects raise blood pressure.
And drugs target this system, like losartan.
Losartan is an ARB angiotensin receptor blocker. It stops angiotensin II from binding to its receptors.
So it lowers blood pressure.
Right. And drugs like lisinopril are ACE inhibitors. They block the production of angiotensin II. Both are very common hypertension meds.
But they can cause issues with anesthesia?
Yes. Patients on ARBs or ACE inhibitors have a higher risk of developing significant hypotension during anesthesia, and it can sometimes be harder to treat with standard vasopressors.
So what's often done?
It's common practice now to hold these medications, stop them the day before elective surgery to reduce that risk.
Got it. And you mentioned those handy drug name endings.
Yeah, it can be helpful clues.
Yeah.
ARBs often end in sartan, like losartan.
Okay.
ACE inhibitors in sarpril, like lisinopril. Alpha blockers in osin, like terazosin.
Yeah.
Calcium channel blockers often in sartapine, like amlodipine. Aldosterone antagonists like spironolactone are a bit different.
Still, useful rules of thumb. Okay, what about unstable heart rhythms leading to metabolic acidosis? How's that managed?
Right. Bad rhythms can cause poor perfusion. Tissues don't get enough oxygen. They produce lactic acid, leading to metabolic acidosis.
And the treatment? Bicarbonate.
If the acidosis is concerned severe on blood gases, intravenous sodium bicarbonate might be considered to buffer the acid, but it's used much more cautiously now.
Why the caution? What are the downsides?
Several potential problems. It can cause severe plasma hyperosmolality.
Make the blood too concentrated.
Yeah. It can also paradoxically worsen acidosis in the brain fluid, causes high sodium levels, hypernatremia, and importantly, generates carbon dioxide. Yes, the buffering reaction produces CO2. If the patient isn't being ventilated adequately to blow off that extra CO2, they can develop hypercarbia, high CO2 levels, which is also bad.
And it affects potassium.
critically. Bicarbonate lowers serum potassium by shifting it into cells as it buffers hydrogen ions. So you have to watch potassium levels very closely.
So not a simple fix for acidosis. Lots to consider.
Okay, TET spells in infants. Hypercyanotic attacks.
Yeah, typically seen in infants with certain congenital heart defects, like tetralogy of Fallot, usually around 2-3 months old. They become suddenly very blue, cyanotic. What triggers them often happens spontaneously, but can be set off by crying, feeding, exercise, anything that excites them.
What's thought to be happening physiologically?
The leading theories involve either a spasm of muscle in the right ventricle outflow tract, the infundibulum, or a sudden drop in systemic vascular resistance, the body's overall blood pressure. Either way, it increases the right to left shunting of deoxygenated blood across the heart defect.
More blue blood bypasses the lungs and goes straight to the body. Exactly. Leading to the cyanosis.
How do you treat it?
Phenylephrine is often the first choice.
The alpha agonist again?
Yep. By increasing systemic vascular resistance, it encourages more blood to go the right way, through the lungs, reducing the shunt.
Makes sense. Anything else?
Esmolol, a beta blocker, can also work, possibly by relaxing that infundibular muscle spasm. You definitely want to avoid things like isoproterenol that lowers systemic resistance that would worsen the shunt, and keeping the baby calm and well hydrated is also important.
Got it. Target the shunt. Okay, switching way over. Sildenafil, Viagra, how does that actually work?
It's for erectile dysfunction, obviously. Erection relies on nitric oxide release in the penis.
Oh, no.
Right. Nitric oxide boosts levels of cyclic GMP, CGMP, and CGMP relaxes smooth muscle, allowing blood flow in.
So sildenafil boosts NO or CGMP?
Indirectly. Sildenafil inhibits the enzyme that breaks down CGMP. That enzyme is phosphodiesterase type 5, PDE5.
Ah, so it stops the cleanup crew for CGMP.
Exactly. By inhibiting PDE5, sildenafil lets CGMP hang around longer and build up in response to sexual stimulation, making the muscle relaxation and blood flow happen more effectively.
So it enhances the natural process, doesn't trigger it directly.
Correct. It requires sexual stimulation to initiate the NO release in the first place.
How does that compare to other drugs mentioned? Yohimbine, nitroglycerin?
Very different mechanisms. Yohimbine is an alpha blocker, different pathway. Nitroglycerin and hydralazine are direct, smooth muscle relaxants, not specific like sildenafil. Enalapril is an ACD inhibitor, totally unrelated. Milrinone inhibits PDE3, mainly used for heart failure. Sildenafil is quite specific for PDE5.
Interesting specificity. Okay. Drug-eluting stents, DES, placed in coronary arteries. What's the key follow-up?
Dual antiplatelet therapy, DAPT. Absolutely critical. Usually aspirin plus a P2Y12 inhibitor like clopidogrel.
To prevent clots inside the stent thrombosis.
Exactly. Stent thrombosis is a catastrophic complication. DAPT drastically reduces that risk.
How long do people need to be on both drugs, especially if they need other surgery?
For drug-eluting stents, the general recommendation has been a minimum of 1 full year of DAPT before safely stopping the P2Y12 inhibitor for elective surgery.
1 year minimum?
Yes. Though guidelines might evolve with newer stents, if surgery is needed sooner, sometimes a bare metal stent might have been chosen initially, as those typically require a shorter DAPT duration, maybe only 1 month minimum.
So the stent type dictates the antiplatelet duration. Got it. Now, heparin-induced thrombocytopenia, HIT, sounds paradoxical.
Right.
Heparin causing low platelets and clots.
It is paradoxical and dangerous. There are 2 types. Type I is mild, non-immune, usually insignificant.
Okay.
Type 2 is the bad one. It's an immune reaction.
How does that work?
The body makes antibodies against a complex formed by heparin and a platelet protein called platelet factor 4, PF4.
Antibodies against heparin PF4, then what?
These antibody complexes bind to platelets, activating them and causing them to be cleared, leading to thrombocytopenia, often a 50% drop in platelets.
Okay, that explains the low platelets. What about the clots?
That's the really dangerous part. The antibody complexes also bind to the lining of blood vessels and endothelial cells and trigger thrombin generation. So you get this prothrombotic state, high risk of venous and arterial clots, despite the low platelet count.
Wow. So what do you do if HIT happens?
Stop all heparin immediately. Unfractionated, low molecular weight heparin flushes everything.
And if the patient still needs anticoagulation, like for bypass?
You must use a non-heparin anticoagulant. The main choices are direct thrombin inhibitors, drugs like bivalirudin, argatroban, loperamide.
Bivalirudin was mentioned specifically.
Yes, it's commonly used in cardiac surgery for HIT patients. While protamine allergy is another reason to use these, HIT is a very strong indication. Heparinase enzyme is another potential option sometimes.
Crucial to recognize and switch anticoagulants.
Okay.
Nearly there. Catheter-related bloodstream infections, CRBSIs. Risk factors.
Main things are how many bacteria are on the skin where the line goes in, and the vein's tendency to form clots around the catheter, which bacteria love.
Which site has the highest risk?
Generally, femoral lines in the groin carry the highest infection risk.
And the lowest.
Observational studies suggest subclavian lines under the collarbone have the lowest risk. That's why CDC often recommends subclavian access when possible.
Location matters for infection risk. Good to know. Finally, back to clopidogrel one last time. Its mechanism.
It irreversibly blocks the P2Y12 receptor on platelets. This receptor normally binds ADP, which is a key signal for platelet activation and aggregation.
Irreversibly?
Yes. Once clopidogrel binds to that receptor on a platelet, that receptor is knocked out for the entire life of that platelet, usually 7-10 days.
So, no antidote drug. If someone is bleeding on clopidogrel.
Correct. There is no pharmacologic reversal agent. The only way to rapidly restore platelet function if needed urgently is to transfuse platelets, give the patient fresh, unaffected platelets.
Wow. Potent and long-lasting. Okay, that really was a deep dive. We covered a massive amount of ground.
We certainly did. From basic measurements like the Fick equation, all the way to complex interventions like VADs and managing emergencies like HIT or cardiac arrest.
Yeah, and seeing how it all connects, the physiology, the drugs, the potential complications, it's intricate.
It really is. I think so the key takeaways are just how much we can manipulate physiology, like with cardioplegia reducing oxygen demand so dramatically.
Right.
The careful balancing act needed for conditions like aortic stenosis or with VADs.
Definitely.
And the importance of understanding these potentially severe drug reactions or complications like protamine reactions or HIT.
Absolutely. It really highlights the delicate balance of the whole cardiovascular system. Makes you think, doesn't it?
It does, how everything needs to work just right.
Maybe leaves our listeners considering, given how complex and finely tuned the heart and circulation are there any lifestyle choices or aspects of health they might look at in a slightly different light after hearing all this?
That's a great thought to end on. Definitely food for thought.
Thanks for joining us for this deep dive.